Hi, I'm Mayank Pathak. I'm a physician. I work at the Parkinson's and Movement Disorders Institute in Southern California, in Orange County. I've actually been asked to talk about a couple of things today. First, an introduction to what spasmodic torticollis is, and I won't belabor the point because most of us here know. Everybody can see the screen up there? I think if I had some other suggestion, Justin, for future meetings for the AV department, you could have two screens so that the patients with rightward torticollis could sit on one side of the leftward. But I can tell you just personally, as somebody with 20 years of chronic neck pain, and I don't have torticollis, but have chronic neck pain, that sitting at these meetings at either extreme many times, and it's excruciating to my neck. So several years ago, we wrote a book, and I'm going to read you my little definition, sort of haltingly, which I've marked with an airline napkin here, of what spasmodic torticollis is. And I've kind of written this as a simple definition for everybody. Spasmodic torticollis is a neurological disorder that results in an involuntary turning or twisting of the head and neck, causing them to assume a forced abnormal posture. It's difficult for a person with ST to voluntarily move his or her neck and head back to a normal, neutral position. So let's examine that definition. There's two words in that definition. The first term is a neurological disorder, and that's to distinguish it from other causes of abnormal head and neck position. Meaning abnormalities of the spine and the neck, deformities of the spine, deformities of the musculature in the neck. A lot of babies are born with a twisted neck, and that's usually a mechanical problem, not a neurological disorder. Other causes can be a slippage of the bones of the neck, causing a kyphosis or a forward bending of the neck, or other neck disorder. And that is not spasmodic torticollis. This is a neurologic disorder. And the other word that I want to focus on is involuntary. This is an involuntary abnormal head and neck position. Some people like me who get a pain in the neck may hold their head to one side or the other to make themselves more comfortable. And in fact, I was just doing it over there before I stood up. And that is also not spasmodic torticollis. So abnormal posture and abnormal movement of the head or neck. So to understand the neurologic disorder a little better, I've drawn a simple diagram of the motor part of the nervous system. And here we have a brain cell up here in what they call the motor cortex. This is a primary motor neuron, and it sends a wire down here that crosses over the midline and comes down and communicates with another neuron, which sends a signal out to the muscle. And when that muscle gets a signal, the muscle contracts and the body parts that it's attached to move in the appropriate direction. So this is called the primary or the pyramidal motor system. But that's not all you need. You can't just tell a muscle to move. You also have to tell it things like how fast to move, how hard to move, how slowly or quickly to modulate the force depending on what you're lifting or what you're pushing against. And also, you have to set a resting tone to the muscles. Muscles are not completely flaccid, except when we're deeply asleep. So all of this is the responsibility of a supplementary motor system that's not drawn here, and that's called the extrapyramidal motor system. This is the pyramidal, and that's the extrapyramidal motor system. And the extrapyramidal motor system exerts influences on these primary motor neurons and the signals they send out to the muscles of the body. And the extrapyramidal motor system is located right here in the middle of the brain. If you just sliced my head open right about here like so, you would see a group of nut and berry sized clusters of nerve cells deep in my brain. And this is the extrapyramidal motor system, and that's the part that modulates things so that you can move and be coordinated, and also set the resting tone of your muscles. And this slide just shows what happens when a body part moves. A muscle is relaxed and it's at length, and when it contracts, it gets shorter and pulls on the respective body part. So that's what happens in your arms. In spasmodic torticollis, or in your neck, what it's pulling on is these neck bones. So these, with a normal set point or a normal tone of these muscles, at rest, the head is generally pointed in a straightforward direction, not too much to the left, not too much to the right, not up or down. So pretty much your neutral set point, and that's what's shown here in this slide. This is actually Dr. Daniel Trong. He posed for me when I drew this picture. And so that's Diane Trong's husband. And you'll see much more of him as we go along. So when the signals from the extrapyramidal motor system go awry, a lot of different movement disorders can result. Problems in this group of nerve cells cause disorders like Parkinson's disease. They cause dystonias, and cervical dystonia, also known as spasmodic torticollis, is one of that group of disorders called dystonias. So there are when we talk about the abnormal posture of the head and neck, we talk about four principal directions. If there's forward flexion, that's called anterocollis. Backward flexion or retroflexion. And this is just straight rotational torticollis, a third direction. And this is called lateral collis, just a sideways tilting of the head. And the different sets of muscles that are abnormally contracting and under tension account for the different movements or the different head positions that you'll see if you look around this room. And usually when I see a case of spasmodic torticollis, it's not simple. It's not that somebody comes in usually just in one direction, anteroflexion, retroflexion, lateral collis, or straight torticollis. It's usually a combination of one or more of those directions, as is exemplified by this dashing young fellow here. This guy has rotational torticollis, and he has a little bit of lateral collis. So he's rotated and he's tilted. And again, it depends on the set of muscles involved. I'm going to just quickly go through some of these muscles. This is the most commonly known muscle that is involved in torticollis, probably the most commonly injected with botulinum toxin. This is called the sternocleidomastoid. And if you look, it attaches at the collarbone and it attaches behind the ear. So if you take your hand and span it between the inner part of your collarbone and the back of your ear, and just think if that muscle is abnormally contracting, and you can do this by bringing your fingertips together and see where your head has to go in order for those fingertips to actually come together. This is the direction that it's going to move your head. I put this first also because it's the counterintuitive muscle. The right sternocleidomastoid rotates your head towards the left, and the left sternocleidomastoid towards the right. And that's sometimes a little stumbling block for people to understand, and to understand why I'm injecting the muscles I'm injecting. So this is the person's left sternocleidomastoid, and this is the movement that it would cause. It would rotate his head towards the right and also tuck the chin a little bit. So that's kind of the force vector of that muscle. Two muscles here that elevate the shoulder. One is called the trapezius muscle, and one is called, underneath that is called the levator scapula, because it elevates the scapula or the shoulder blade. So when these two muscles contract, they elevate the shoulder. They elevate the shoulder and they pull it in a little bit. And this is a pretty accurate depiction of what those two muscles do. Now, as many years as I've used this slide, I've been perennially perplexed as to why such a prominent bald spot has been depicted here. One more muscle that's frequently overlooked in the back, splenius capitis. This is also a diagonal muscle. And it also both rotates the head and pulls it in the backward direction, just as the sternocleidomastoid pulls it in the forward direction. So this is the person's right splenius capitis muscle, and looking at him from the front, this is the direction that it would move their head. It would rotate their head slightly towards their right side and pull it backwards a little bit. And you can also do this by sticking a finger on the back of your head and then sticking one right on your spine and then trying to pull the two fingertips together, and you can see which way it'll move the head. I wanted to keep the talk very brief, so I'm skipping over a lot of different muscles involved, and there are a lot of deeper muscles in the neck that make it a much more complex disorder and much more difficult to treat, especially with the botulinum toxins. These are the superficial muscles, and we usually inject these first, but a lot of times the movements are caused by deeper muscles that are right up against the spinal column, and they're more difficult to find and more difficult to inject. I have slides of those as well, and I can pull those up if you want, if we have some time. This slide is in here, but I wasn't going to talk about this, but it's the hidden symptom of spasmodic torticollis, and that's the visible part is the abnormal head position or the head tremor, and that's kind of what you can see. What you can't see is the pain. Some torticollis patients have a very marked and visible abnormal head position and no pain, and some patients have just a slightly odd head position, but they have lots of pain and everything in between. So pain is the hidden symptom of spasmodic torticollis or cervical overcontraction of the muscle. If you've ever had a Charlie horse, you know what that pain is like, and just imagine having that all the time. There are other sources of pain too. Here you can see the dark bands represent the rubbery discs that cushion in between each of the vertebral bones of the spinal column. And with chronic wear and tear, those discs can get mushed and mashed, and they sort of push out in the backward direction, kind of like a rare hamburger patty being squeezed under a spatula. They're kind of rubbery on the outside and liquidy on the inside. And they'll squeeze and bulge out backwards. And that can touch nerves at each level, at each of those discs. A set of nerves comes out of the spinal column, and one goes to each side, and if they impinge on those nerves, it'll cause pain. They can also, in extreme circumstances, impinge on the spinal cord, which hangs down the spinal canal like a big, long Coney Island hot dog. And it can actually go in there and squeeze it in the extreme case. Also, what you can't see here is that there are joints, not just rubbery discs, but they're actually almost bone-to-bone joints between each of these spinal bones, and those joints can undergo wear and tear and arthritic change, and they can become knobby, like the knobby knuckles in an arthritic person's hand, and that can be another source of pain as well. So important to recognize pain as a component of spasmodic torticollis. So I'm going to, my talk is going to be much shorter. You guys are going to be running way ahead.
That may actually be helpful.
That's my countdown, I take it?
Well, no, you're doing fine.
Okay.
Yeah, you're doing great.
Okay. So oral medications have somewhat limited utility in treating dystonias in general, and within dystonias of cervical dystonia or spasmodic torticollis, and to me these terms are synonymous. So I'm just going to talk about two broad types of medications that are employed for this. One group I've lumped together as what I call anticholinergics. And I've chosen to call them by the name of the major side effects that they have. So there's two medications, you can read these, Artane and Cogentin. I don't even know if they make the brand names anymore. I think they've all gone to total generic names. But these medications are medications that cause you to dry up. They dry up your saliva, they dry up your eyes, they dry up your skin. They also cause some degree of sleepiness. but they can make some dystonias a little better, or odd movements a little better. Many people who look like they have a primary dystonia that started out of the blue actually have a disorder that's caused by a medication. Some of those medications are certain types of psychiatric drugs and also certain types of gastrointestinal drugs. They will cause dystonias, including a cervical dystonia, or they'll cause a tremor. These medications are mostly the antipsychotic medications that they give for people with hallucinations. Actually, they used to give mostly to people with hallucinations, and now, as these things go, the use of these medications has burgeoned, and they give them to people with all sorts of psychiatric disorders, from anxiety to depression to just sleep problems. These medications, I'm at the risk of getting up on my soapbox. They're kind of my favorite medications because they account for a lot of simple consultations I get in the office, and I can fix the person by getting them off their psychiatric medication. But a lot of times the psychiatrists or treating doctors have to give those people Artane or Cogentin along with their psychiatric medication to counteract the side effects of the psychiatric medication. So these can also be employed in treating spasmodic torticollis. Again, there are dose-limiting side effects, which I've already gone over. The other medications I've also chosen to lump under the rubric of their major side effect, which is sedation. These medications are all in a pharmaceutical class called benzodiazepines. And they're all the PAM drugs, or what I call the Valley of the Dolls drugs, if you ever saw that old movie. These were kind of the medications they were, the pills they were all using. But, not to make light of it, I prescribe these medications. So, let me just back up. I do employ these medications for my patients. They're all just about the same. Some are a little longer acting, some are a little shorter acting. Every doctor has their favorite. And I really don't have a favorite. And these medications have a muscle relaxing effect, and they also seem to diminish the abnormal output of the brain. They can be used to stop epileptic seizures, and perhaps by the same mechanism, they diminish the abnormal brain signals that cause muscle contraction and dystonia. Of course, they only have one major side effect, and that is sedation. So that limits their utility. Also, if you try to quit cold turkey from these medications, they do have a significant withdrawal syndrome. And so you need to build up slowly and come down slowly off the medications. These are controlled substances. They can be addicting. As I joked about earlier, they have been abused. We have generally found that in the spasmodic torticollis and the dystonia population, that has rarely been a problem. It's usually in the multiple other uses to which these drugs are put that we see the problems with addiction and drug-seeking behavior. We really have not had a big problem with it for whatever reason in the dystonia population. I'm not going to talk about this much because you're going to get a whole nother lecture on surgery and denervation for dystonia and for spasmodic torticollis. Let's see what else we have here. No, that's it. Except that they all work. They all work well. They're all injected into the different muscles. So a doctor has to identify which particular of those muscles are most active in a given patient, and then has to decide to inject those particular muscles, and has to decide which of the toxins they're going to use and how much of each toxin they're going to inject into each of those muscles. And the toxins take about a week to start working, and then they work for several weeks.